So now Dr. Viktor Krebs is going to talk to us a little bit more about treating infections, about revisions, and kind of some additional uses that may show the promise of Prontosan. So Viktor, thanks for being here.
Oh, thank you for inviting me. So I titled this DARE for PJI in 2024, Application of Advanced Debridement Concepts. We've been doing this for a long time, using different things to try to get rid of infection. Obviously, at the Cleveland Clinic, we have one sent in every day. So our fellows, our residents, co-staff, we're all taking care of PJI continuously. So this is something that's evolved. A lot of what I'm talking about is under study, and a lot of it is not on label. Here's my disclosures. Nothing to do with this talk. So I'm going to start off with some x-rays. Everyone wants to see a case review. So this is a 75-year-old male, 6 months status post right total knee replacement. He's 14 years status post the other one. So 6 months later, he goes in, has a tooth extraction, a jaw infection, and ends up with a systemic infection with what ended up being strep mitis oralis. So here's his x-ray, 6 months post-op. You can kind of see the little robotic markers there where the pins went through. But he comes into the office with a hot, swollen knee, fevers and chills, CRP elevated, SED rate on the rise. His aspiration, 10,500 white cells. So if that comes into your office, you're washing it out. You don't need a culture. This is going to the OR. So this patient went to the operating room. And this is one of the ways that we're using Prontosan. We're combining it with an ultrasonic debridement system, in my opinion, the best of both worlds. And this has basically occurred. The system that we use, the ultrasonic debrider, has been out for 15 years. And it requires the use of some type of antimicrobial solution. So it ultrasonicates and suctions at the same time. And if you just do it with saline, you actually make the patients worse by driving the bacteria into the tissue and creating a very negative atmosphere. So we've found out over time that you've got to use something with this system so that the bacteria are neutralized the moment they're ultrasonicated. The first thing we used was bacitracin, foamed up, couldn't see anything. We finally got to Prontosan, and Prontosan came into the U.S. in 2 waves. The first time it came in as a nanoparticle and a device. So we had a hard time getting it into the Cleveland Clinic when that occurred. And then when it was reintroduced, it was much easier to get in. So the team here has worked really hard to make this easy to get into the hospital. The cost is very, very applicable to what we're doing. So this just shows the ultrasonic debrider, and I felt that it's probably best just to show you videos of what we do. So the Prontosan has a surfactant and the PHMB. These are nanoparticles, and they are there to get rid of biofilm. If you add that to an ultrasonic system that's going to irritate the biofilm off of the metallic surfaces, we've hypothesized that you're basically going to end up with a much better debride and retain and potentially a better long-term result from this. So we're currently studying this. We've got a prospectively collected retrospective cohort of patients, but this just shows what we're doing in a total knee that has an acute infection. And in this case, the infection was not identified before we went to surgery. We had no idea what was actually in there. And it's important, if you looked at the last video, the polyethylene was in. Polyethylene then needs to come out. You need to get into the back of the knee. You need to debride all of the metallic surfaces. So you can see with this device, we're moving it around on every surface that you can get to. The patella is also done in a similar manner. And it's important not to touch the metallic part of this ultrasonic device to the metal. I turned the sound on this off because it is absolutely intolerable screeching. It does. It sounds like nails on a chalkboard. But if you go into every one of your debride and retains and you use a biofilm destroying agent and ultrasonication, I think you're going to end up with a better long-term result, and hopefully we'll be able to prove that. Our anecdotal results are very good. I think our return rate for infection is very low, but we're really quick to jump on these. Hemostasis is also critical, so once this is done, I let the tourniquet down and I treat any bleeding. You don't want a hematoma in a wound that you just scraped out, so if you've got that, you've got to take care of it before you close. And this just shows what the wound looks like after it's been debrided. You can see the x-rays of the patient post-operatively. So new poly, tourniquet down, and DARE complete. So our goal with this is to eradicate biofilms without replacing the implants. I think every one of us in this room wants to go into the operating room in an infected case and not cut everything out. You know that taking everything out and putting in some type of a spacer, be it a static or a mobile spacer, creates a lot of morbidity for the patients. When you go through the literature, though, it's really, really, it's humbling to see the success reported with staph between 13 and 90%, gram negatives 27 and 94, and strep 40 to 94. So these rates of cure with debride and retain are so far out there that you can't even believe it. I mean, the range there is just unacceptable. There are some more specific studies that show that there are better results, but basically what you're seeing here is a coin flip. So if you have Staph aureus, it's 50-50, gram negatives, you've got a 68% chance. Strep is 58, and Enterococcus is 51. So in most of these situations, we're really not doing that well with what we've done in the past. And I think what most people have done in the past is they'll open up, they'll do an aggressive synovectomy, they'll rinse with solutions for different amounts of time, and then get out of Dodge. This is an article, one of the most recent ones, on the debride and retain. 970 patients in a systematic review and meta-analysis ranging from 18 to 92. The success rate ranged from 55 to 90% in the articles that were there, with a mean value of 71%. So if a DARE procedure is going to give you 71% success, I would tell you that you should be considering it in every acute infection. This is obviously not for the chronic infection and the infection that's been there with the draining sinus tract. This is another procedure that's out there, DAPRI, debridement, antibiotic pearls, and retention of implants. That just shows a picture of it. I've found that putting the calcium sulfate pellets in there creates an osmotic environment and actually results in a lot of swelling. So we tried this and kind of went away from it after doing the ultrasonic debridement. This is another study that shows that in revision arthroplasty, 88 patients who underwent a DARE after a revision within 90 days, between 12 and 19, had a success rate of 68% after 2 years. So this is good. So you've got revision surgeons who are very, very adept at debriding and synovectomizing, and you're getting a 68% on a revision. So this is good, but I think if you apply more advanced techniques and modalities, I think that we can improve this even further. This is just going to show a case of one of my disaster cases. So I didn't create this. It came in to me like this. 57-year-old DDH, multiple revisions. But if you look at that femoral stem distally, that's not coming out. If you take that 57-year-old stem out, you don't have any femur left, and you probably don't even have enough room to put a stem in the distal aspect of it. But they came in pain, swollen, with P. acnes. This just shows the stem and why I didn't want to remove it. So this was our spacer. So we went in, took the socket out, we did a dual mobility cemented spacer and filled a defect with an augment, but we retained the stem, ultrasonicated it, and used Prontosan around the top of it. This was in the first wave of Prontosan. So this was the spacer. So we put cement around the top of the implant, we debrided it with the appropriate solution and ultrasound, and she disappeared. So 5 years later, she shows back up in the office with this. which you would expect. This was not designed to be a weight-bearing spacer. This patient was all over the place walking around on this. So you look at the x-ray and you're like, oh my God, she's infected again, here we go. But we did all of the workup, and in this case it was sed-rate CRP, aspiration, SPECT CT with WBC scans. There was absolutely no evidence of infection whatsoever. We did go in and we put on a bipolar and assessed the defect, and this defect was not reconstructible with any augment combination that I could come up with. So we put a bipolar in it, debrided it, cultured it, and then did a custom implant. So in this situation, prior infection with C. acnes, debride and retain, use of Prontosan. In these situations where you've got a well-fixed stem, there are times that you're not going to take stuff out. And I think using advanced technology to do this is the best way to go. So here's another one, debride and retain plus. I love the plus. So 14 with debride with conventional DARE. The DARE plus is modular component exchange and stem retention. So that's the case that we just did. And then there's 21 with two-stage revisions. When you look at this, the two-stage, the 2-year reinfection-free survival was only 25% for the DARE, but was 60% for the DARE plus or for two-stage revision. So DARE plus and two-stage revision in this study were equal, and I think that's pretty important. The 5-year amputation-free survival, 84% for DARE plus or two-stage and 48% for DARE. So these are really important numbers. When you're dealing with cases like this and patients' limbs that are at risk, you should be thinking about a DARE before you do it. So in a case like this, DARE is the first line of treatment when you have an infection. If you take this out, you're basically dooming this patient to an amputation. So reinfection-free, reoperation-free, and amputation-free survival was similar between DARE plus and two-stage revision at the 2 and 5 year marks. So I think this is a great study. It shows us that we can do things in a better fashion, and I think that this system that we've got with effective biofilm busting solutions and ultrasonics work. So here's a 67-year-old male construction worker, had a Birmingham resurfacing done. He weighs 348 pounds and 6'5", so this is not fun. You're not going into this saying, yeah, we're going to have a great day in the OR. So when you look at this, they come in with pain. First thing I'm thinking about, pseudotumor metal ions. So we got metal levels, and for hip resurfacing, a chromium level of 3.2 is pretty normal. So after we got that, sed-rate CRP was 19.8 with normal being less than 0.5. So obviously we were dealing with an infection. He was seen initially at an outside hospital and they didn't know what to do with him, so they shipped him back to the clinic. We got an aspiration and he had 187,000 white blood cells in his hip. It doesn't get any worse than that. We didn't have an identification, but this is obviously going to the operating room. In a case like this, there's nothing to exchange. So you either debride it and retain it or you excise it. This guy was adamant about not having his hip taken out, as was I. So this is a perfect situation for a debride and retain. So it did grow Staph aureus out later, and I'm just going to show you how we use this system with the Prontosan. So this just shows soft tissue debridement. So any soft tissue area that's not healthy looking, we scrape it out with the curette end of this. On the metallic surfaces, we run the ultrasonic device over the metal, hovering over it so that it doesn't screech and scratch and make horrible noises. But this is actually, if you look at it compared to using a scrub brush or a toothbrush or some other method of debriding the metal, to me this makes a lot more sense. And in our early clinical results and for these patients, we've seen a lot of benefit. And you can just see when you look at that video how this thing is creating a layer of biofilm busting fluid on the metal. So it's irritating the biofilm off, it's delivering the biofilm busting solution, and you're going to get the best possible. So this is us reaching down into the socket. Probably the most important thing to see there is that suction tube is full of fluid. That fluid and the debridement on the socket surface is also critical because the biofilm's obviously there. And this just shows it getting in a little bit deeper and digging into the hip. I'm beating the dead horse here. So nanoparticle ultrasonication has been published. There's a number of people looking into this. It definitely shows in vitro studies that sonication plus a biofilm busting solution is a great option for reducing all biofilm off of a metallic surface. So we're translating that actively into patients in situations that are very difficult. So the Prontosan ultrasonic DARE, I think, is going to become something real. We're going to have some data coming from the Cleveland Clinic, and I'm going to be encouraging the company to support further studies on this and take this to another level. So I think a DARE should always be considered. I prefer to have an organism identified. So if you have a chronic infection or an MRSA infection, you have to think really close about how you're going to treat this. Those are the ones that tend not to do well. You need to have an organism that's sensitive. I think all acute infections, it's something that you should consider. All non-draining frail patients, if you do a 1.5 stage or a 2 stage in them, I think that you're going to put them at risk for problems. Obviously, any extensive reconstruction that's not easy to remove, and a lot of these end up on chronic PO suppression. Thank you.